Great. Good morning, good evening, good afternoon, everyone. I see that our waiting room is almost clear now, so I think we're happy to get started. Thank you to all those that are participating with us here today. If you are logged into this session, you are here to learn more about the experiences of sustainable financing as a critical component to reduce child health inequities in low and middle income countries. Our discussion today will focus on childhood pneumonia in Ethiopia and Tanzania. And as we begin with introductions, I would really encourage all of the participants to feel free to drop in their name, organization, and where you're joining us from today in the chat. Would be great to see that. And I'll also request for bandwidth issues for those that are joining to please turn off videos if you can and only come on when you're speaking or presenting. Thank you so much. So happy to get started. My name is Nausha Haji. I'm a Senior Market Shaping Officer with Results for Development, or R4D. R4D is a not-for-profit organization focused on improving access to healthcare, improving educational outcomes, and reducing malnutrition in low and middle income countries. The way in which this work is done is by supporting countries to do this work themselves, working alongside country agents such as government partners, as well as civil society organizations, as well as the private sector, as a way to drive sustainability and address urgent priorities, while also taking a holistic approach to system strengthening across these countries. I'm currently based in the Tanzania office, and I work on a portfolio of projects within the market shaping practice to increase access to life-saving medicines for particularly mothers and children. I have the privilege of being your moderator today, and I am accompanied by 4 very experienced individuals who have extensive experience in addressing child health inequities at both global and country level. And so as I am introducing each one of you, if possible, I'd like for you to come off camera and quickly wave or give a nod to those that have joined us here today. I'll start by introducing Mr. Malez Sullivan. Mr. Malez is the National Newborn Child Health Program Desk Head at the Federal Ministry of Health in Ethiopia. He has over 12 years of experience working in both government and non-government organizations, and he holds a master's degree in child health and pediatrics. Next, we have Dr. Felix Bundala, who is actually seated next to me today. He is the Assistant Director of Newborn, Child, and Adolescent Health within the Ministry of Health in Tanzania. Dr. Bundala has over 15 years of experience working within the child health space here in the country, leading the development of critical child health policies and guidelines. He holds a master's degree in health policy and management and is a PhD candidate in facility health systems and newborn care outcomes. Today, we also have Ms. Samantha Durdog, who is joining us. She's a senior program officer with R4D's market shaping practice. Her work focuses primarily on increasing access to life-saving medicines within the reproductive, maternal, and newborn child health space. And she has experience working across a number of geographies within sub-Saharan Africa, including Uganda, where she led some of the childhood pneumonia work that we will be speaking to today. I just want to note Samantha is joining us from Liberia today and is trying to, as best, optimize her connectivity. So she will remain off video, but hopefully will be able to participate as a presenter today. I also wanted to invite Yowelida Tesfaye, or for short, Yodi. Yodi is an expert in market shaping and supply chain approaches with more than 13 years of experience in the public sector, the private sector, as well as the NGO space. Yodi is currently an associate director with R4D, leading health system strengthening and market shaping efforts in Ethiopia. And she has played an active role in advocating for sustainable financing of reproductive, maternal, and child health products. I just wanted to say thank you to all our presenters and panelists, Mr. Melez, Dr. Bundala, Samantha, and Yodi for joining us today, and very much looking forward to hearing from all of you in the next few moments. Thank you for all those too that have joined. For those that joined a few minutes past the hour, please feel free again to introduce yourself in the chat with your name, organization, and the location from which you're joining us today. And also just a quick reminder for those to save our bandwidth. Sometimes challenges, I'll ask that everyone keep off video unless you are speaking or presenting. To briefly give you a rundown of today's session, we'll start by Samantha providing a brief overview of the childhood pneumonia program and market shaping work that's being led in Ethiopia and Tanzania, which is really focused on increasing access to amoxicillin dispersible tablets for the treatment of childhood pneumonia for children under 5. And we will be focusing particularly on the component of sustainable financing, where Mr. Melez and Dr. Bundala will speak about their sustainable financing journeys within country to achieve sustainable financing for amox DT. Also have Yodi stepping in for Samantha in case anything goes wrong on her connectivity side. After the presentation, I will be facilitating a panel discussion with our presenters here today. We do have some targeted questions, but also welcome questions from the audience, and we will do our best to respond to as many as we can within the session. If we are unable to respond, then our panelists will compile some of the responses and share back after the conference. So before we move into the presentation, I thought it would be great to start with a poll for today, and hoping that that poll can be put up on the screen. The question is on your screen and hopefully will show up in poll format. And it is asking globally, how many children under the age of 5 die from pneumonia every year? And just gonna check that it's on. We see that there's already a response in the channel. I'm not sure if the poll has already been launched. If somebody from the team could just confirm. Could I ask whether anybody can see the poll at the moment? Maybe Yodi, if you could just let me know.
Yes, I can see it.
Okay, great. Could we have the responses up if we're ready, if enough people have responded? Okay, I think the responses are loading. We have a few for 700,000, about 50% saying above 700,000, a few saying above 800,000, and a few saying above 500. I'll give it a few more seconds as we get the participation rate a bit higher. So over half have responded. Feel free for others to respond as well. Okay. So it seems like we have about 65% participation rate, and seems like there's a close tie between above 700,000 children under the age of 5 dying every year globally, and another close runner-up is above 800,000. So according to UNICEF, over 700,000 children die from pneumonia every year, including 153,000 newborns. And sadly, most of these deaths are preventable. So I'd like to pass now to Samantha to talk through some of the work that we have been doing to address kind of the starking figure, trying to address how we could really stop these preventable deaths by increasing access to the first-line treatment of amoxicillin DT. So with that, Sam, I'll pass to you to take on from here.
Great, thank you, Nausha, and thank you everyone for joining us. I hope everyone can hear me okay. Okay, full results. Okay, wonderful. Yes, thank you all. So as Nausha mentioned, my name is Samantha Durdak. I'll go ahead and kick off our brief presentation on the efforts R4D has taken to support increased access to amox DT with the governments of Ethiopia and Tanzania before passing to my colleagues. So childhood pneumonia is the leading single cause of death among children under 5 globally. However, we've seen through our work that this disease area does not receive the same level of support and resource commitments as one would think should be provided given its high burden. So if we can click just once. Thank you. So as you can see here on the left-hand side of the slide, the teal graph or the teal line for acute respiratory infections or ARIs, of which pneumonia is the most common, it accounted for about 17,000 of all, or 17% of all under 5 deaths in Africa over a 4-year period, followed behind by malaria and diarrhea. However, if we shift to the right-hand side of the slide, you can see that over a 10-year period, pneumonia only received about 7% of the total amount of global donor funding committed to malaria and HIV/AIDS combined. So I just want to sit with this for a second. The highest burden of children under 5, or highest leading cause of children under 5 deaths was due to pneumonia. But in comparison, it does not receive nearly the same amount of funding support. And while this funding analysis does not take into account domestic funding from governments themselves, it is indicative of the financial resources globally that are provided and the disparities across disease areas. Next slide, please. And so access to treatment, we believe, is one of the many interventions required to reduce preventable childhood pneumonia deaths. You need prevention techniques such as vaccines, you need treatment, etc. But treatment is certainly one of the key interventions that is needed in order to reduce these preventable deaths. And we're seeing that greater investments by both government and partners collectively are needed to scale up access to amox DT, which is the WHO recommended treatment in low and middle income countries. So R4D's market shaping practice, we use a holistic market shaping approach, and we've been working with the governments of Ethiopia and Tanzania to scale up amox DT access. As you can see in the top left corner here, we have supported the 2 governments since about 2015. We started our work first with a market diagnostic to understand the challenges to scale up, and then have been working with the governments to develop a strategy to address those challenges and providing that catalytic support to carry out the strategy. And then finally, we've been leveraging lean approaches to generate an evidence base for what interventions have and have not worked in terms of our ability to alter and improve and shape the market, and where those remaining challenges might lie. So these technical approaches have all been applied in a holistic manner, where R4D initially playing the market manager role, which has now been taken up to some degree by the government, certainly. We've been working though across actors in the regulatory, the supply, the demand, and financing spaces to ensure really close coordination, because all of these actors working together is what makes the market well primed to provide access. And in this manner, we are able to improve access to amox DT over time. So by shaping the market to ensure that the appropriately designed product, amox DT, is available, that it's affordable, that it's of good quality, and that those in the health workforce are aware of it. And then finally, that it's appropriately used. And so the results of this holistic market shaping approach, it focused on improving sustainable financing for amox-CT through the application of co-financing agreements with governments of Ethiopia and Tanzania, in addition to addressing key supply, demand, and regulatory barriers. And as a result, we've seen that in both countries, significant improvements in availability of amox-CT across facilities, where you can see here with Ethiopia on the top and Tanzania on the bottom, you can compare the left-hand side of the bar graphs to the right-hand side and see that now both countries have reached and achieved over 90% availability of amox-CT products within their health facilities, which has been a remarkable improvement across both countries. We've also seen the flip side of that improve, where we've seen a reduction in the percent of stock out. So as you can see on the right-hand side of the slide here, we've seen that over time, as availability has increased correctly, stockouts have decreased in both countries. So both countries saw about a 75% reduction in stockouts. So now we'll just take a deeper look at the specific challenges and interventions taken to drive the improved amox-CT market in both countries. So as mentioned, we began our work in both countries by assessing what the market barriers were in order to inform the strategy and future implementation required. And in both Ethiopia and Tanzania in 2015, we found key challenges across 4 market buckets. So when we look at the regulatory bucket, policies were misaligned. So for example, we were seeing treatment guidelines didn't quite match between various levels of the health system. In supply, we found few manufacturers were registered in both of the high burden countries, and certainly none of those had a WHO or SRA body providing quality assurance. And then on the demand side, the capacity of both countries to forecast and procure amox-CT needed to be strengthened because at the time they were relying solely on UNICEF to both quantify and procure. And then lastly, on financing, in both countries, amox-CT was actually facing a severe funding cliff with a significant donor funding program coming to an end and no plan in place for sustainable financing. And with that, I believe I'm handing the presentation actually over to my colleague, Mr. Millais. So over to you, sir.
Thank you very much, Dr. Felix and my colleagues from different countries. And I would like to thank for giving me this opportunity and chance to present on amox-CT in terms of Ethiopia, how the accessibility and financing sustainability. So as you can see from the previous slide, the TS activity and impact and the barriers was identified. So while holistic TA is needed to address all markets barriers to drive impact, sustainable financing was key to move partners and domestic resources and avoid another funding cliffs. So this was the main financing key message and movement in terms of Ethiopia. So as pneumonia was the leading cause of deaths in Ethiopia for the last maybe decades till now. So we have a strategic plan to sustainable this important drug. So as you can see from this slide, Ethiopia was significantly increased the demand and increase the significance of procurement and the budget 2020 to 21. So as you can see, starting from 2017, which was 39%, and at 2018 was also decreased again, and at 2019 was also 40% was reached, and currently is at, at 2021 is reached 100%. So in this matter, marketing amoxicillin DT part of revolving drug fund, which enables health facility to use their own budget and procure the medicine. And the second one was increased allocation of Minister of Health mobilized SDG full fund for amoxicillin DT procurement, and supporting establishment of health full fund that consists of domestic mobilized resources that can use it for commodity procurement. So this is what I can say from the previous to now. Ethiopia also has a dedicated financing resource for sustainable in this matter, and we have also a plan in the HSTPT also mentioned, and all documents, all documents and all activities are included the amoxa DT, as far as the health professionals and the people also aware of this medicine. So as you can see from the previous slide, amoxa DT in Ethiopia is accessible at in around 93% at all facilities. So this is what I can mention so far. Thank you so much. Over to you.
Great, thank you, Mr. Melez, for that. I'll pass it on to Dr. Bundala now to speak about the sustainable financing journey in Tanzania.
Thank you so much, and I think I'm already introduced, Dr. Felix. I won't repeat that one. I will briefly share about the financing for protecting of pneumonia and severe, but just recognize also Tanzania, like other countries, pneumonia takes the number 2 as the cause of under 5 deaths after neonatal conditions. There we do have other causes like diarrhea and malaria. Now, sharing on how we are doing the financing, I would like to say when the LFD setting, we had like 2 years of experience of using amoxicillin DT, and by that time, UNICEF for the procuring this for the 2 years. So the information from our medical department, by then, they had no confidence of procuring the right batch for being make it available the countrywide. So when we are still in that frustration that we are lucky, the LFD came in, and we basically started finalizing our document together. And by that time, we were doing the standard pediatric treatment guideline, but also the adult standard treatment guideline. So we made sure that the amoxicillin DT now is replacing the syrup, which was being in use by that time. So we really planned it together. We understood the situation together, and we also made the forecasting and the quantification together. And the argument was that when we were starting in 2017, that's the ladder, as you can see, the line in between. So it was supposed to be the LFOD as is coming in support. Then the Ministry of Health is starting like the contribution of 10% each, then 30%, you can see 50, 60 to 100%. The 100% meaning that is the full now financing by the government. It was unfortunate in 2020 hit due to factors like the COVID, the government financing. It was not that easy to meet the commitment. So we think we are very thankful to RFOD very much by being the flexible, the RFOD with the partners, they were that much flexible. So they had to compensate what the government would have done by that time. But we all now we are very thankful now with the plan that by end of 2020, by end of this year, now the 100% of this commodities, the of the team, will be funded by the government. So we have already told our countries, our facilities, now to start putting the budget for procuring these commodities, as it is now shifting from being the vertical from the R4D, now it should be as the horizontal, the commodities, where the facilities they plan to procure, and it is being procured from the medical store department, and thereafter, but this one should be available to the under fives in free of charge, as the Tanzania police focuses the target group, the under fives and the pregnant woman for her services basically is free of charge. That's as far as I can share about the Tanzania experience.
Great. Thank you so much, Dr. Bundala, as well as Samantha and Mr. Melez for sharing some of the experiences across Tanzania and Ethiopia on increasing access to amoxicillin dispersible tablets and sustainable financing journeys. It seems as though much efforts and commitments have been made by the government across both of these countries to address the burden of pneumonia in a way that is government-led and sustainable. And I'd like to dive a bit more deeper into these pieces through our panel discussion. As I mentioned earlier, we will have some targeted questions for the panelists to open it up, but welcome questions in the chat box as well. And we will do our best to address as many as we can throughout this session. And if we don't get to it, we will try to share some responses after the conference. So with that, I'd like to jump right in and I'll direct the first question to you, Mr. Melez, around your experience in Ethiopia with sustainable financing. Thank you for sharing some of the pathways that were taken and the innovative approaches in Ethiopia to achieve sustainable financing. Given your experience, what would you say have been some of your biggest learnings around achieving sustainable financing for this child health commodity? And what would be your best advice to other country governments and countries who are on the path for sustainable financing for life-saving commodities? And to ensure we keep time, you have about 4 minutes to respond. Thank you.
Thank you very much, Dr. Flex. So in terms of Ethiopia, the system we follow was, first of all, Ethiopian policy and strategy is open to facilitate and to support any innovation and evidence-based and WHO recommended drugs or other interventions. So as far as we know, the amox DT was recommended by WHO. So in 2016, we have revised the IMNCI guideline, training guideline. So at that time, we include amoxicillin DT as a first line treatment for pneumonia. So our government was committed to support on this area, and we have also put on the drug list in Ethiopian drug list and at the APL. At the list. So the government was committed to plan for this sustainable financing for amox DT, and also we have aligned with partners. Some partners have interested to support on under 5 activities, under 5 interventions. So we align with some partners to support on training or something like, and the government also committed for this main and leading cause of death for pneumonia, as far as amoxicillin was first line for treatment. So we committed from the SDG, and in fact supporting partners like R4D. So the government is highly committed in this area, and the financing was mainly the source of financing was from the SDG directly. So this was the main point to achieve and to sustain the financing resource. And other countries can learn from Ethiopia that first of all, the leaders and the policies should be follow according to the recommendation, WHO recommendation. So if WHO recommendation is accepted and followed, some funds may sustainably support, and the government leaders should be committed in this area. So and in some guidelines and drug lists should be listed. So the government should be allocate enough source of money for this R4D for sustainable treatment. So this is what I can say. Thank you very much. Over to you.
Thank you so much, Mr. Melez. I think you had so many golden nuggets in your response there, but I think what I heard very loud and clearly is that there is a need for government commitment and leadership, but in addition to achieve sustainable financing, there seems to be other pieces that also have to be in place. You mentioned things like having aligned guidelines that are aligned to the best practices and WHO recommendations, having plans already in place that recognize that these products are truly life-saving and need to be prioritized within the country. And if you can have some of those pieces and government commitment in place, sustainable financing, though takes some time, it comes a bit easier, I think is what I've heard. And there are some prerequisite steps to get to sustainable financing that looks like at other pieces, including the regulatory and having the right political environment. So thank you so much for that response. Samantha, I'm wanting to pass this question to you as well, maybe in the next 2 minutes, leveraging some of your experience in the global landscape as well as Uganda. What would be some of your reactions to Mr. Melez, or some additions that you'd want to include?
Can I add something about some points? Sure. Which when we get feedback from the facilities, and when we doing supportive supervision at the community and the facility level, we get a lot of professionals are prefer amoxicillin rather than the other drugs. So since the regional health bureau heads and Warada heads are powerful to push the government's decision, so they recommend to have this kind of drug. So according to their need, the government also give a positive feedback. So this is what each regions and professionals and regional leaders are supporting for sustainable. Yeah, thank you so much. Over to you.
Thank you for that addition as well, Mr. Melez. Samantha, would you like to come in and maybe add or comment on Mr. Melez's response?
Yeah, of course. No, thank you so much, Mr. Melez. I think you definitely, as Nosha mentioned, raised some really valid points, particularly around, you need that political will, so to speak, or prioritization within the government itself. Maybe I can just add on a partner perspective as well. And I think something that as partners that we need to bring to the table is the notion that sustainable financing is a process, not an event. And so this kind of implies, I think, in my mind, two different approaches or two different aspects of approach where a TA mechanism is hoping to support a government to achieve sustainable financing. And the first one is that, the partner or the TA provider, you have to come with the plan to provide the TA required by the government to support them in their pursuit of the sustainable financing. So just setting a target of, by in 5 years, this will be transitioned to the government, that doesn't cut it. You need to help and support the identification of what the sustainable financing mechanism looks like. And then, as I think Mr. Melez was alluding to, that piece around advocating and mobilizing the various individuals, departments, whatnot within governments to get behind that plan. It takes time, it takes resources to do. So I think as a TA provider, really ensuring that you're planning for that. And then the second piece, I think, is as Dr. Bundala mentioned, the flexibility is important. So I think both the Tanzania and Ethiopia example offer two great examples for, both countries have, created a sustainable financing for MOX-DT, but it was done in different ways at different speeds. There are some stop and goes based on the realities in the country context. And I think that's really important to keep in mind as well. Is, it's an arc or a process that you're moving to, not just going to happen one point in time, and the flexibility that partners and donors need to provide as countries identify the sustainable financing solution that fits their context best is really important.
Thank you so much. Another few golden nuggets from Samantha as well, given her experience. But I think the piece around it being a process and not an event resonates significantly, I think, with probably many in this room. Just reflecting on some of the work in Tanzania as well. I mean, the program has been here for 7 years, and we had even developed a 5-year co-financing agreement. So that in itself shows kind of the time and the pace at which sometimes these things do take time. But I think if done in a way that's well thought out and planned for, it's easier for everyone that is around the table. So thanks for sharing that, Samantha. I really appreciate some of those responses. I want to shift gears a little bit and move on to the next question, which I'd like to direct to Dr. Bundala. Dr. Bundala, given your 15 years of experience within the child health space, can you briefly talk to us about the specific activities and interventions related to both service delivery and access to commodities that your country has taken to really strengthen primary healthcare and address inequities in child health?
Thank you so much for that last question and being asked to share my experience of that. And I try to group into three. One being the preventive activities, the curative activities, but also the promotive ones. When I'm talking about the preventive, basically we start with the immunizations programs, which Tanzania is among the countries doing very well and this immunization. We all understand these antigens for prevention of diarrhea or prevention of pneumonia. We basically help very much in the prevention of pneumonia in the future. But also in terms of the preventive, we do have different programs. For example, the WASH program, I'm talking about the water and sanitation programs. But also into the housing, we need to impart of the preventive measures for the pneumonia. But also, when these preventive measures fail, what we need to prepare our facilities to do the curative laws. The most common intervention we do is integrated management of childhood illnesses, of which according to the WHO, but also even the Tanzania guidelines, we wish to have more than 60% of the primary health service trained in the primary health facilities. for them to be able to do an appropriate assessment, that appropriate assessment of the under 5s who goes into facilities. And thank God, the last report of Tanzania demographic survey of 22 showed almost out of the 10, almost out of the 10 under 5s who get an RE, about 8 will go to this facility to seek care. So we need to have the facilities where the providers really have the knowledge and the skills to do the appropriate assessment, but also after do the appropriate classification, but identify very well the treatment needed, because sometimes if the providers doesn't know that this should be given amoxicillin, they may end up giving another medication. So we need the people who really understand what the appropriate medication, right dose, right frequency, and the right durations. But also provision of the follow-up, the follow-up visit. So this is the kind of the things we are doing. We're implementing the MCI, which we go all over the facilities. But also we should not forget about the promotive part, using the community health workers. We are doing that. But also we basically promote the issue of the MCI, the pneumonia, especially on even 11th November, where this is pneumonia day. We have different messages being circulated through different medias about telling the population what is the pneumonia, the burden, but also the way it is being transmitted, how it can be prevented. But if someone have the signs and symptoms, should seek care as early as possible. So those are kind of the things we are doing.
Great. Thank you, Dr. Bundala, for that response. And I think what I really resonate with in your response, Dr. Bundala, is this piece around taking a holistic approach. So what I heard a lot about what you said was focused on both services and commodities and working on them together to help strengthen primary healthcare systems. So for pneumonia, for example, there seems to be a lot of work being done around training of individuals through IMCI, doing some of the preventative work through the vaccines, where there's a clear link to commodities, and then also working through these community health workers to do some of the promotion and some of that awareness at the community level. And so really appreciate your perspective on this and looking at strengthening primary healthcare, both from commodities and services and how they come together to really drive stronger systems. So really appreciate that response. And just keeping track of time here, I am going to move on to the final question that we have planned here, and I'll direct this one to Samantha. You know, going a bit broader and thinking about addressing child health inequities around the world. Samantha, given your in-country expertise, as well as your bird's eye view of the global landscape, what are some of the critical areas of support that you would like to see from global and regional stakeholders for improved access and equity to child health programs, and in a way that's an accountable and transparent manner? I'll start with you, Sam, maybe 3-4 minutes, and I'd also like to hear from Mr. Melez and Dr. Bundala on this question as well. So Sam, to you.
Yeah, thanks, Nelsha. I'll try and respond quickly to make sure there's time for Mr. Melez and Dr. Bundala to add their perspectives as well. I think on my side, just to take a high-level view, in general, there's a need for greater advocacy and dedication to the MNCH space overall. I think to date, partners and donors have been of the mindset that government should be able to manage the MNCH medicine markets, given MNCH products have relatively low costs in comparison to other areas. However, through some of the analyses that the R4D team has done in the MNCH space, we've seen that governments are in fact providing the majority of funding. They're leading the majority of procurement for the MNCH market, but gaps persist. And unlike other product markets for like program commodities, so think of vaccines, of family planning, of HIV, the MNCH space, it's very fragmented and it can be really difficult to navigate, I think. And so, I mean, to date, I feel like the majority of partner support has been provided to really focus on introducing MNCH products to the market. So focus on that product introduction activities. This particularly was happening around the early days of the UN Commission on Life-Saving Commodities. But that dedication to scale up has been lacking, whereas you see it more happening in the other program markets. So yeah, so I think that greater commitment to support to countries in catalytic ways to scale up access just generally needs to be strengthened. And maybe just one final note, I think the 90% availability of amox DT that we've seen achieved by the governments of Ethiopia and Tanzania, it's a great achievement. It's remarkable, especially considering where things were at just a few years ago. And I don't want to discount that by any means, but when I see those figures, I think often to conversations I've had very recently in the reproductive health space, where a country will see 90% availability of injectables for family planning or of IUDs, and that 90% availability is viewed as unacceptable. So there's a kind of a seeing the same measurement, but taking two very different viewpoints. And I think a lot of that has to do with what areas are we prioritizing as a global health community, and what is and isn't kind of the measurement of success that we're working towards, and how are we supporting ourselves, whether we're a donor, a country, a partner, to prioritize the resources and interventions needed to achieve that.
Thanks so much, Sam. I think that last point is quite I'd say eye-opening, but I'd invite Mr. Melez maybe first to respond and add on to this question.
Thank you again, Dr. Felix. So when we think about the pneumonia and the number of days in a year or monthly, I am personally ashamed, because pneumonia should not be a leading cause of days in this area in the 21st century. Preventable disease is not a much a problem. So, but practically Ethiopia is suffering from pneumonia in under 5 children. So currently we have 17% in pneumonia in under 5. So the problem is multi-disciplinary, because pneumonia by itself is not a cause. So we can also manage and prevent the other areas like wash, nutrition, and immunization, because every child should be well nourished and immune to any disease. Because if a child has low immunity, we can attack by simple disease rather than pneumonia. So we need a systemic support, which is the WHO system building blockers, which are capacity building we need, and quality of care, and we need also data quality. This data may not be accurate. If we have accurate data, this data may be increased more than this one. So sustainable financing for pneumonia treatment or amoxicillin only is not a solution for us. So it's a multi-sectoral collaboration, and the whole system should be supported the quality of care, and every professionals at the community level and the facility level should trained how they can prevent and how they can treat in pneumonia to prevent the death. So this can be one need, one support from global and regional stakeholders, and we can also support a best practice from other countries which are low under 5 mortality, especially by pneumonia. For example, South Africa is not much attacked by pneumonia, even may not, maybe they will they will forget the pneumonia by name, because the pneumonia days under 5 in South Africa is very low. Even the neonatal mortality is very low. So we need best practice from other countries, from Africa, maybe from other global countries, which are best practice in preventing pneumonia. So this is one thing, and the other question is the child health program and intervention and accountable. So the other one is it should be accountable for their work. Every profession should be accountable for their work, because sometimes accountability is loose in Ethiopia. If a child dies by diarrhea, not necessarily by diarrhea, even if a child dies because of misdiagnosis or by not caring well, they are not accountable for that. So accountability should be accountability, and transparency should be on the table, on the system, and this should be implemented practically. And also the diagnostic materials for pneumonia, maybe sometimes delay and lack of oxygen may attack these childs. And the referral linkage also another problem in our country. If a child have severe pneumonia, but the child lives far away from infrastructure where there is no access to transport, they may delay and they may die because of lack of oxygen, and also they can also die because of lack of.
To interrupt, I'm just conscious of time. I think we've made some incredible points here for global and regional stakeholders to think about. I do want to give a quick chance to Dr. Felix Bondala here as well. And so happy for you to continue to share some thoughts in the chat if there are some other salient points you wanted to make. But Dr. Bondala, I'd like to pass to you as well, maybe for 1 more minute of your response here, and then we will wrap up. I noticed that a lot of the responses or questions in the chat have been responded to, so we'll pass to Dr. Bondala for a minute, and then we will wrap up.
Okay, thank you so much about the critical areas. Number one, basically looking through the children's, and I will divide into 3 parts. Number one is newborn care. An estimate of 100,000 under 5 being dying in Tanzania per year, 70% being the newborn. So we really need to focus by having essential newborn care, but also care of the small and the sick newborns. The second part is to the child care. Although we see this progress, but we need to sustain these gains in terms of providers with skills, commodities, medicine, and equipment. They need to be there if we are to achieve the 2030 targets of Sustainable Development Goals. But number 3, we also need to focus in adolescents, where they also hit with a different number of challenges. So we need to promote use of HIV prevention, into prevention of teenage pregnancies, but gender-based violence, issue of nutrition and non-communicable diseases, mental health, all other parameters which face these groups. I think this is main focus.
Thank you, Dr. Bundala. Appreciate everyone's responses to this question. I think with about a couple of minutes left in today's session, I just want to quickly give a big thank you to the planning committee for this conference for giving us this platform to share some of our learnings today, to our panelists for sharing all of their learnings and insightful perspectives around strengthening primary healthcare and what it really takes to get there through sustainable financing as a core arm. If I may, I'd like to summarize some of the key learnings I've taken away from today's session, maybe categorizing them as key messages to 3 different groups of stakeholders that may be around this virtual table today. I think for country governments and country change agents, this piece around sustainable financing and strengthening primary healthcare systems, it's a process. It takes time and a lot of alignment across different parts of the government and political will. I think Mr. Melez and Samantha spoke to this quite well around having the right political environment and political will so that these child health preventable illnesses and preventable deaths are prioritized within countries, which then helps to pave a path forward around allocating the right number of domestic resources to achieve sustainable financing for life-saving commodities as well as other areas. With sustainable financing, I think this piece around having the regulatory alignment supported, making sure that providers and prescribers at the ground are well trained. It's part of the system, and we have to take care to look at all. I think for implementing partners, Samantha's comment around focusing not only on new product introduction, but also focusing on scale up as a gap that we've started to see within R4D, particularly within the MNCH space. And so keeping tags on that. And I think for global stakeholders, a few points to think about around continued support for pneumonia and preventing these deaths, as well as areas such as neonatal health, adolescent care, and training and accountability, as well as availability of commodities and diagnostics, all have to be part of a system to help us achieve our SDG goals of ending preventable deaths in children under 5, and also strengthening primary healthcare systems. So thank you again for all the session, for all the speakers, and for all the questions and those that joined us today. Very much appreciate having you all here, and enjoy the rest of the conference. Thank you so much. Have a great one.